As part of our commitment to improving patient care at Wake Forest Baptist Medical Center, those of us physicians in the Heart Center who perform these procedures as a group decided that we were going to make a transition from using the femoral artery as our preferred access to the radial artery as our preferred access. Because of that, the entire staff, both the physician side and the medical side, made a huge commitment in terms of education, time and effort, and because we went through the sort of growing pains of a program that was dedicated to transradial artery catheterization, we were able to achieve, I think, some efficiencies and excellence that allowed us to perform this in the vast majority of our patients now. We started this procedure about 2.5 years ago in an attempt to improve the quality of care we provided to our patients coming to the cath lab at the Heart Center. In those 2 years, we've performed probably over 3,000 transradial cardiac catheterizations, and we feel have gained a tremendous experience and satisfaction in performing this procedure. When we embarked on this program of transitioning to transradial catheterization as our preferred strategy for this procedure, we realized that we needed to have a broad-based effort that included not only the physicians, the fellows, and the staff, but clearly the patients and their families themselves. So we set up each of the labs identically with the basically equipment that allowed us to perform this in a simple fashion. We actually stopped prepping the femoral arteries so that we could show the confidence that we had that we were going to actually perform this in most of our patients. And the last part of this is that in the recovery areas, we had special unit built that really embodied the less invasive, I think, safer procedure. We've called this the radial lounge. Other people call it a radial recovery area, but there the families and the patients are able to recover in a sitting position with a simple hemostatic band on their wrist. And because of the lighter anesthesia and sedation we use, they're able to get up and move around much more quickly. We think that the vast majority of patients can undergo a diagnostic heart catheterization through the radial artery with either 4 or 5 French catheters. There are procedures, of course, that involve coronary intervention, sometimes non-coronary vascular interventions that require tube sizes, catheter sizes that are much larger than can be accommodated through the radial artery. Many of these we try to identify ahead of time so that we know that femoral access is the route that we need to take. Our Heart Center, in particular the Transradial program, has really shown to us that it's important to assume a leadership position in this area. And to that end, we have acted as a training site for other hospitals that are interested in making the transition. We've had physicians come and visit us and watch us and sort of get firsthand experience of the procedure. The staff have come from other hospitals, work closely with our staff, seeing all the details and the steps that we take to make this a successful procedure. We're also looking at a cost effectiveness of the equipment, time that it takes to perform a catheterization through the radial approach as well as the femoral artery approach. We've just successfully presented an abstract at the TCT and have others submitted for the American College of Cardiology. So through our clinical research, we are trying again to remain in the forefront of efforts to make transradial catheterization the best possible.